We all live off the DSM like a matrix, so this room is empty. That makes no sense. Would like one person from each table ask somebody to come in here? Or no? No? Okay. No? Okay. Well, do it empty.
Unless there's any takers. All right, it's working. Can you all hear me okay?
Can't hear you.
Oh, okay, that's better. All right, thank you for that. And thank you for the introduction. And also, can we give a big round of applause to the Health 2.0 team for making this happen? Thank you so much. This has been incredible. It's only day one, half of day one. Hopefully you guys are all fed, doing good. So we're going to start this off by asking everyone a simple question. Look around you for a moment. Just take a moment, maybe a few, just look around. And I know there are empty chairs in here, but recognize that every fifth person or every fifth missing chair over there has been diagnosed with a mental health disorder. And this is real. This is affecting us on the daily. This is affecting every one of us, regardless of what end of the spectrum we're on. And so in that line, we are here to talk a little bit about what the diagnosis is in terms of the DSM, or the Diagnostic and Statistical Manual. And I'd like also all of you to give a big round of applause to our panelists, our esteemed panelists who've flown all the way from everywhere. And much like all the other panelists, or all the other panels that I've heard speak, we're also a diverse group of people here. We have licensed clinical social workers, we got autism service providers, professional counselors and therapists, psychologists, healthcare operators, and so much more, just in the five of us. I'm the outlier. I'm a hardware engineer, and I come in here from a different way through purpose, and we'll talk about that. But before me, I'd love to pass on the microphone to everyone here on the panel, and just introduce yourself. And in doing that, I would really like for you all to at least give us a little bit of insight into what your purpose is, what drives you into what it is that you're doing, and what brings you to the conference as well. Do you want to start over there, Dier?
Okay, hello everyone. My name is Dier Dikaha, and I am a licensed clinician and the owner of 7P Healthcare Services Incorporated and 7P Consulting. So 7P stands for Proper Prior Preparation, prevents piteous poor performance. The more that you're properly prepared in anything in life, it would help the outcome for being pissed or poor, okay? Everyone has a mental disorder, or every fifth person. I have a mental disorder, I'm OCD. But instead of crying over it and being boo-hoo, I use my mental disorder to my advantage. And I had to teach this to other people. So 7P Healthcare does mental health, wraparound case management. We work with substance abuse. We have a Suboxone clinic. We're in Ohio, DC, Maryland, and North Carolina currently. And I would love to team with anyone in this room in other states that we're not in, and I could teach you how we can bring the same concept to that state. But I'm a caseworker that turned therapist. I went to school 10 years after as a caseworker. Why? Because the clients were telling me all their information. I was getting all the tea before the therapist was. They was talking to me more than they was talking to the therapist. So 10 years later, I decided to go to school and get my master's to become a licensed therapist. But what does license mean? License means insurance company. So we're going to talk about the DSM and why the DSM is here, because of licensure for billing purposes. But when you get down to the grit of what someone's problem is, it's because you have a relationship, you have an understanding. So 7P doesn't worry about the schematics or the problem. We're focused based on the strengths. We know everybody got something going wrong, but what do you have going good? What are the positive? What are the strengths base that we can pull from to get you out of your dysfunction, your unlevel, your level of dysfunction that's currently not allowing you to live daily without therapy? So thank you.
My name is Brett Warner. I'm from Miami, Florida. I own an autism services company. We're tri-county, multiple, like 60 staff, 70-something clients. We do in-home, in-center. We're building our own centers in school. Our big thing, though, is not working with the kids, it's working with the parents, okay? So we have a separate wing of the company called Expanding the Spectrum. So if you're a parent and your child gets diagnosed with ASD or on the spectrum or Down syndrome or something like that, we now have a group of trainers that are going to teach parents what your kid is capable of while we are working with your child to get them to that skill level, right? Now, I'm going to circle to the DSM, right? As many of you know in here, I probably think you do because you're on a healthcare conference, Asperger's doesn't exist anymore, right? PDD, NOS doesn't exist anymore. Now it's just ASD, right? So I'm giving you one example of DSM, right? So you get a 299.0 code on your face for the rest of your life, no matter if you're Elon Musk or a kid that's running into the wall every 5 seconds. Same diagnosis code, right? So how does the payer know, oh, I'm poor, no, I'm super rich, oh, I was abused, I was this. The DSM doesn't have any of that, right? So in the DSM, we just say 3 numbers, a letter, this, that, a modifier, but really, that one doctor that gave you that diagnosis is not calling the specialist, right? Are they? When you go to the specialist, did they say, oh, your doctor called me, I already talked to him, we know what's going on with you? No, right? So the problem with the DSM is that one doctor will diagnose you with a code. Another doctor will diagnose you with a code. You'll come to me with 500 different codes, right? And we're all just, sorry to say it, in the Holocaust here, right? We have just codes on us. It doesn't work. So I guess at the end of this, we're going to try to find a way and get you guys involved, please, of how do we make a coding system work for diagnoses that are on spectrums, right? Clinical depression, you could be super depressed, you're going to kill yourself, or you could just be a little depressed because your company didn't make enough money, you missed a paycheck, right? But it's the same code, right? Totally different. So we're going to talk about that a little bit. I think we could get through that.
Hi, my name is Evangeline Bauer, and I started Come Play STL about 8 years ago. And it came from a need of one of my clients. She came in with a diagnosis of ADHD. And I quickly realized, as we were doing different play therapy interventions, this child could not read, this child could not spell, and they would often flip their letters. And so I quickly realized this is not ADHD, this is a learning disorder. And so when I went to her parents and I said, I'm so sorry, I can continue doing therapy, but I am the wrong therapist. This is the wrong diagnosis for your child. I sent the child away to another psychologist and got diagnosed with a learning disorder. She got the right treatment, and she's thriving today. All of that to say, I started the company Come Play out of a need of having medical professionals as well as behavioral health therapists all at the same table making diagnosis for children. So that's what I do.
Good afternoon. I'm Jill Wiedemann West. I am the CEO of People Incorporated Mental Health Services. People Incorporated is the largest community-based mental health provider in Minnesota. We serve somewhere around 14,000 to 15,000 discrete individuals a year. About 2/3 of them receive more than one service. Our clients are largely disabled by their mental health. These are individuals that are living with multiple barriers. I approach this with a little bit of a different flair. At People Incorporated, we believe that not only do we need to be an excellent service provider, but we also need to be a thought leader. We need to be thinking about what it is that we're doing out there to promote health equity, meaning breaking down the barriers, whether it's language, it's trauma, whether it's an individual that doesn't even have the word mental health in their native the culture that they came from, which we see a lot in Minnesota. We have to find a way to break down those barriers, and we have to find a way to make healthcare available and accessible, because healthcare is one of the great equalizers, right? And if it doesn't exist, it is a much bigger problem. So in addition to our thinking about services and making sure that our clients are in fact moving towards recovery, whatever that recovery means for them, we are also incredibly passionate about moving towards a sustainable healthcare picture and creating an equitable sort of scenario, not just in Minnesota, but everywhere. So thank you for inviting me today.
Thank you. And as go for it. And as I mentioned, I'm the outlier. I'm the engineer. And I came in here through my personal struggles with severe anxiety. And it's really interesting. I asked you guys to do the little social experiment earlier on about looking around and finding the fifth person. We didn't plan this, but the fifth person from the air is me, and we both have had struggles with mental health. And in that line, and in my adult life, struggling with anxiety, struggling with asthma, as well as with sobriety, I really came into meditation and mindfulness about 15 years ago, along with yoga. And one of the things that I really got to learn from that is how it was helping me with my anxiety. And as I started looking into research back in the mid-2000s, I realized there wasn't much. You know, there were some studies being done by a doctor named John Kabat-Zinn. And so in talking to him, what I realized is he was doing some research with monks. These are people who are practitioners who've been out in the mountains doing their thing, and it really didn't help me understand how it was helping me. But I stayed with it, and it did help. But it was when I introduced sound into my practice was I truly able to overcome my ailments. And that's what my purpose and my drive for being here outside my comfort zone. I could be talking about technology, but I decided to be here because this is really important for me, because what I learned in overcoming, in dealing with my anxiety, as you can tell, is that we have to persevere, right? We have the ability, the inner healer within us, and we just have to invoke it. This is not about finding something new. This is about recognizing it's here. And in that, we've created a new treatment modality which integrates sensory immersion as a tool with CBT and DBT. We're funded by the California State. We're in prisons, we're in jails, we're in adolescent treatment centers, recovery centers all over California and Oregon. And so in line with that, and thank you so much there for giving us a little bit of an insight into what a DSM is. Is everybody familiar with what the DSM here is?
Is everyone diagnosed?
Okay.
Sorry, I have to bring some comedies.
That's good, yeah. So the DSM is the Diagnostic and Statistical Manual. This was something that was created back in the 1950s as a way of classifying mental health disorders as well as brain-related illnesses. And through that, you know, in the biggest change from then on, from the 1950s, was in the 1980s when they shifted to a major medical model that is more scientific backed as well as with diagnostic criteria as they originally planned. And then moving on from then, into 2013 was the DSM-5. That's when they introduced a more dimensional approach, removing all kinds of, or including a bunch of subtypes within them. So as we started learning about how these disorders are actually affecting people, they started adding more subtypes, more criteria. And moving into 2022 with the DSM-5, the TR, which is what we are in right now, they've been moving away from the categorical identification of all these different ailments into more of a spectrum-based ailments, one of them being autism, the other being schizophrenia. And I'd like to pass it on to the panel here to talk a little bit about the DSM itself in what you believe is working as it is right now, and also what parts of it do you believe needs mending?
I can speak. So I believe that the DSM right now works to get you a diagnosis if you have an insurance company, that you have a plan, an active plan, which may be not active tomorrow, we don't know, right? Or you have Medicaid, which might not be active tomorrow. The DSM code is supposed to get you treatment, correct? Now, if you have a DSM code for a spectrum of a disability, right? 299.0. I'm sure that if you raise your hand in here, you know what that is? 299? We know, a couple people know, it's autism, okay? The DSM-4 had Asperger's as a diagnosis, okay? Had PDD-NOS as a diagnosis. When they made the DSM-5, they got rid of those. So that means that how does the insurance company or Medicaid or any payer know what the difference between you, who has social skill issues, okay, 299.0, or a 4-year-old who is banging their head bloody into their parents' wall every morning as 299.0? There is no way, right? So the insurance company is going to go, oh, it's 299.0. They're going to do an assessment, they're going to do all that, but they have limits for the 299.0, whether that's a 21-year-old or a 3-year-old, right? So you run into that problem. Same thing with every other diagnosis that's a spectrum. You get one number put on your head, and that's it, right? What if you were abused as a child? Okay? What if we don't look at the whole person? What if we're just looking at that diagnosis number, okay? And we don't go deeper into it? Because you could be diagnosed, 2 people could be diagnosed with depression, but one person could have been abused as a child, lives in a poor area, does this. Should the DSM lay that out so that they get more services versus somebody else? Maybe they should get the same amount of services. What I'm trying to say is that when you give one code to millions of people that are all different, how are you determine how much they deserve or they're supposed to deserve, right, in this country, or how much health care are they supposed to get if they all have the same code, right? So that's my personal issue with the DSM-5. The 4 was easier in the mental health world because it actually broke things down. Mm-hmm. But now, a lot of mental health is just one code. You get the same treatment no matter what, no matter age, whatever, unless you have someone to fight for you. And that means that you can't be on Medicaid. You have to be on something else. You have to have money to have that. So that's just my thing about the DSM, is that when we have 500 clients come in and they all have 299.0, they are not all the same. There are kids that are trying to jump off cliffs. There are kids that are here. There are adults that are doing computer programming. There are people in college that are 299.0, but they all are looked at the same way, right? So it's a black and white versus a gray DSM, and I think that is where it has to move, if DSM should even be here anymore. I mean, So, if anyone else wants to.
Well, so I would say that my problem with the DSM is probably sort of akin to my problem with healthcare. It is a codified world that is intended to bucket very specifically an individual. I'm old enough to remember that we used to call that labeling, right? But that's what it is. It's a codified world. The reality of it is that that's not the world we live in. The world we live in is filled with all kinds of factors that contribute. I often think about how many people just in my neighborhood that never really thought about mental health, never thought about mental wellness, but boy, during COVID, they went, wow, I think I'm a little bit more fragile than I thought I was. Love my family, but kind of tired of them. Really love my solitude, but really need some people. And I feel funny about that. I feel anxious, and I feel sad, and I feel all kinds of things. Well, welcome to the wonderful world of we all have mental health, right? And I think the DSM, in that strict codification, does not take into consideration what healthcare really needs to be thinking about in general to create more sustainable roads, to create better outcomes for patients, and to also, of course, create more equity in the system. And that is to create that integration. The integration of understanding that I can see you, I can do therapy with you, I can diagnose you, I can give you medication. But if you're going back to a homeless shelter, if you're going back to an abusive environment, if you're going back to a non-supportive or somewhere where you don't have food security or any of those, some of those social determinant factors, the likelihood that you're going to be successful, that I'm going to be successful, is non-existent. You know, when you go in to have cardiac surgery, and it's a major invasive surgery, right? Whatever it is that you're doing, the doctors constantly ask you, are you depressed? How do you feel? Do you feel safe? Do you feel happy today? Why do they do that? Because they know that if I do this heart surgery and I send you off to do cardiac rehab and medication adherence, and you don't feel happy, you don't feel safe, you don't feel secure, you're not going to have a good outcome. So it seems simple, but clearly it's not. But that would be my point.
I think the only comment that I have to add to it, having both medical staff in my office as well as mental health staff, oftentimes the DSM says, you know, you're going through the criteria to diagnose for anxiety or depression, and it will say, is there another medical condition that could be more applicable to this patient than just this mental health diagnosis? And so with us, we have the luxury of having the medical staff right then and there to go through what are the medical conditions, how does that look, what are the behaviors of that medical condition, or how would that affect a child in this way. I think for a lot of clinicians who don't have that luxury, they're just, I don't think there's a medical condition, so they diagnose the child with ADHD or depression, but they're not looking at the whole picture because they don't have everyone at the table that needs to be at the table.
So add to it for like 10 seconds, I promise. I think that's the whole idea here, right? Is that if you have a mental health problem and you ignore it, you're going to have a physical health problem, okay? So where does it all start? It starts in mental health. But if you get into a bad car accident, you get physically messed up, right? Then you're going to start having anxiety, depression, all that stuff. They are together, right? So the DSM should not be a book of codes of broken leg, this, that, depression, this. It should be combined codes, because depression causes anorexia, which causes, malnutrition, which causes you to end up in the hospital. Now, no insurance companies are here, but I'm sure that we could really help them out. If you start with the mental health issues and you help those, the physical issues can't, or the opposite way, right? So anybody that's been in a bad accident or something like that has PTSD in here, I'm sure. I'm sure that a lot of people in here have PTSD, right? So why aren't we treating that, right? Are you treating it? No, because we don't think that we should. So that can eventually cause you to stop eating, to stop doing this, to stop interacting with your kids, with your grandkids. This is just all connected, mental health and physical health. That's, I think, where the DSM goes wrong.
Okay, and my take on the issues with the DSM is the labeling, like we talked about. So I've been doing this since 2001, and I work with several schools from North Carolina to Ohio with the IEP and the 504s. And the children are being labeled, and the parents don't like it. You're labeling my child. My child is bouncing off the wall. He's getting suspended every week for the same thing. The teachers are discriminating against my children. So I sit down with the parents and I say, okay, let's look at why your child is getting suspended. Let's look at the issues that we're having. And if you don't hit the criteria of this checklist, you shouldn't qualify for ADHD. So I have a problem with this checklist because I was labeled ADHD. And I have my mother that's sitting here, and she decided, thank God, I'm a child of the 70s, not trying to tell my age, but I'm almost 50 years old, and they wanted to put me on Concerta. They wanted to put me on Adderall. And thank God she had the fortitude and the initiative to say, wait a minute, he's just a little active. He shouldn't be put on medication. Okay, he needs to be stimulated, all right? So give him another assignment because he finished the math assignment too fast. Okay, give him another task. Don't label him. So I think the DSM-5 And the DSM-4 was easier, as Brett said, because the labeling, the criteria wasn't as hard. So the DSM-5 tried to make it harder to qualify or to be classified as ADHD, schizophrenia, bipolar, okay. But I wanted to share this, and then we're going to get on to the good things about the DSM-5. If a person, a football player, an elite, an athlete, gets traded from the New York Giants to Miami Dolphins, that's separation anxiety. He just had to take his whole family. Even though he has all the money in the world, how do we know that he's not dealing with some issues, but he doesn't hit the 6 out of 9? So his therapist might not label him with anxiety disorder. But what about that foster child that's 8 years old that got beaten or got abused by their parent and now they're in foster care? That's separation anxiety. So, and I digress, but we can go on, but that's a few of my issues with the DSM-5, because if you don't hit the checklist, okay, I'm not any better than anyone, and I say this in my trainings. Therapy isn't new. Therapy's been going on since the beginning of time.
Since they built this pyramid here in Luxor.
But the relationship building, you get results if you have a relationship with the client that you're dealing with. So when you find out that, okay, he's only 3 of the 9, dang it, he needs 6. Forget the DSM-5, let's talk. What's going on? What happened at home? What happened at school? And then you realize, okay, he is borderline, so I would write a unknown or unspecified. And when they took that out in the 4, that's what made it harder to label them. So I think that's some of the benefits.
Well, thank you for that, everyone. And one of the things that I think is a common theme here is the labeling, the branding, the identification for the rest of your life, right? Because once you're in the system, and if you are, then you know difficulties that everybody's facing here. And in that line, let's talk a little bit about how the DSM came about in terms of like who is the one that has created the DSM, right? Because somebody has to sit up top and say, you know what, these are disorders, these are illnesses, these need to be diagnosed, and these need to be treated, right? And so when you think about it, it's a 27-member task force that created the DSM-5. There's 13 working groups, 160 clinicians, and 300 advisors. And this has been created by the APA, or the American Psychiatric Association. And so if you look at the formation of these groups, these task forces, and these advisors, you really look at it and say, where is the representation from the patient? Where are the patient groups coming in to talk about what it is my clients need? So moving into this conversation, looking at what the DSM is intended to do, the standardization of diagnosis, the utility in reimbursement with insurance, the categorization for research and treatment, creating reliability, creating consistency, and really being able to structure the entire content so that it can be presented to everybody out there, including the psychiatric drug regulation agencies, the health insurance companies, pharmaceutical companies, legal system, policymakers, psychiatrists, psychologists, clinicians, therapists, the individuals, the family. Everybody needs to talk about this in a certain way. So there's a lot of factors that go into why it is the way it is. And now, moving forward, in terms of what it is that the DSM should look like, right? And again, the question may be even down to whether it should be the DSM or if it should be a completely different model. The DSM group has already identified this, saying that, the way that it is, in the way that it's progressing, there needs to be some basic changes at the grassroots level. Right? What that looks like has not been identified. And let's talk a little bit about that, shall we? All right. So in that, we talked a little bit about what it is that we liked about the DSM, though there wasn't a lot of that. There was more about what is broken with it, which is fair because you guys are in it. The other part of it comes to, moving forward, what are, if any, other models that we can look at and say we could take some of these ideas, concepts, and then essentially either transpose it to the DSM or to completely revamp it and improve it. So, any thoughts?
Denmark. I mean, I hate to say it, but Google on your phone, Denmark's health system, okay? They don't have labels for people. There are diagnoses. Everyone gets treated the same, right? In this country, the DSM, in my opinion, and anyone here, obviously we're on a panel, can disagree, and any of you can raise your hand and disagree and get a mic. But I think that the DSM, if we're going to have a book that literally puts a code on your health, right? There should be modifiers on that code, okay? Where are you from? What's your family like? Before you go see a doctor, if they diagnose you, they should be asking you, you know, in all the pages that you have to fill out online, on almal.com, on whatever you're going on all those online websites, see a doctor in person, right? Talk to them about everything that's going on. If they recommend you to another doctor, tell them to call that doctor, sign the release of information, okay? Tell that doctor everything that's going on with you. If we start that way, maybe eventually the DSM will have some modifiers on there, okay? So I go into the doctor's office. I've been really depressed this year. Okay, depression code, boo, 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 okay? But then if the doctor says, why have you been depressed this year, right? Do I send you to a psychologist or a psychiatrist, right? 5 minutes. If we send you to a psychiatrist and they put you on 5 medications in the first 5 minutes that they see you, which raise your hand if you know psychiatrists that do that, okay? Everyone does, all right? Then they're addicted to drugs. Then they're on medication. The psychiatrist doesn't know how to take them off it. Yeah, their anxiety is gone because they're taking meds, all these things. The DSM should not just say anxiety, code blah, 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 because then your doctor's going to send you a psychiatrist, they're going to give you a benzodiazepine. And then you're going to get up and up and up on it, and then you're going to have a seizure and end up in the hospital, right? So the DSM needs to be fixed in a way where there are not consequences for what another doctor will do when they see your diagnosis. That's all I have to say. Anyway.
Okay, we got 5 minutes. The DSM needs to be more culturally context-driven, okay? Raise your hand if you think a book can tell you how to raise a child. So how the HE double hockey sticks can we look at a book to tell us how to treat a person? Understand? So it needs to be more culturally centered around each individual's different. I gave you the example of the football player who has anxiety disorder, and I gave you the example of the 8-year-old. They're two different spectrums. So it can't be cookie cuttered. That's my take.
It's important. I think everyone should raise up for this.
So brain science is still so at the beginning. And I think when we create this definition of the beginning, the middle, and the end with a diagnostic code, what we really do is we stifle our ability to truly understand what we are capable of in the area of brain science. And so the idea of modifiers, the idea of creating those functioning and assessment pieces that are part of it, let the diagnostic and statistical manual be the beginning of a grand effort to create a middle that ultimately creates an end that teaches us something.
And I'd like to sort of take this opportunity to say where I am and what it is that we do with sensory immersion. You know, we take every individual as a person that doesn't have a diagnosis, because as they come into our sensory rooms and into our sensory pods, and as they walking out, feeling a little more integrated into whatever it is that they have, because one of the biggest things is coping. Whether it is the difficulty that you're having with what you're facing, or whether it is the improvement that you are having, right? Really understanding and saying, this is really happening to me, and it can happen to me. Being able to say that, walk out of there, and say, you know what, I want to do something about this, right? And so that part of the bottom-up approach towards treatment also needs to be looked at, versus somebody coming from up top and saying, this is all you have, and this is all you can live with for the rest of your life.
Sounds like the economy. Just kidding, guys.
Oh.
Questions?
Please.
I think this is going to, I'll just speak loudly.
We're gonna hear
I think this has just been a great panel, and I really appreciate your comments, and I hope everyone internalizes what's been said here. Just by way of background, my name is Edward Anselm. I've been Chief Medical Officer of a number of health plans, and as a student, I did attend some DSM-3 discussions. So I have a much more direct understanding of how DSM is written and how it's used, right? And it's the diagnostic and statistical manual. It's not the treatment manual.
Correct.
Right? So
Yep.
the flaw is not in the book.
It's in
The
use.
flaw is in how clinicians use it and how our culture uses mental health care. We don't value mental health care. We're in a profound state of denial around mental health care, and the challenges that you articulate and describe are representative of what every clinician faces in trying to get things done. So the issue is not the DSM, it's how we structure mental health in our society. Thank you for a great panel.
Thank you so much.
I
That was
think
great.
you
Thank
need,
you.
that's great. That was awesome.
Right to the point.
We finished with time, but to comment on what he said, it's 53 people I just counted in this room. If this was a book club and we all got the same manual, the same book to read, we would all perceive it different. So that's also the problem. It's perception as a clinician from Florida to New York. Why did I say that? Because a New Yorker is different than a Floridan, so Floridian. So that also takes into accountability of us as clinicians to dissect and perceive with the empirical images this book and these categories that we're reading on how we can treat the client.
And a New Yorker at 34 is different reading the same book as a New Yorker at 76, correct? So,
Thank you, guys.
Same
Thank
story,
you,
different
everyone.
meaning.
Thank you, everyone.